Just get me know that we are live so that I can start the session. I'm tapping. Can you all see me? Just type there yes and we'll start. Yes, great. So you all know me. I'm Dr. Shivaam, resident in ENT and head neck surgery, and today we will discuss some important Neet Pg, that means some important NBE based questions in a fast review. So I will try to cover most of the important images that they can ask you in your coming NBE exam. And before starting, one tip for you: many people at this time are anxious what to do about preparation for a NEET PG examination. So one tip is you are going to complete all of your 19 subjects. So for your NBE, don't underestimate any subject. All the 19 subjects are important. So it is very important for you to go through all the 19 subjects. Just give one reading of all the 19 subjects. Don't have or don't keep the fear with you. So there should not be any subject where you have fear, because I don't want you to take that fear with you in the examination hall. That fear will hamper whatever performance you are going to give in other subjects and in that subject. If you keep that fear with you in the examination hall, whatever questions come from that subject, your brain will stop thinking. So that is why it is important for you to keep all the 19 subjects ready for your examination, right? And we will start with our first picture, which is a CT scan of nose and paranasal sinus. So it is a non-contrast CT scan of nose and paranasal sinus. And what is it showing? So it is showing you two air-filled cavities or two air-filled spaces. So what are these? These are sphenoid sinus. So you all know we have different sinuses. Now you can identify maxillary sinus, ethmoid sinus, the frontal sinus, but many a times people face difficulty in identifying sphenoid sinus and its component. So your examiners will be targeting this CT image of paranasal sinus for your coming NB examination. So mark this image for your coming examination. And what all things they can ask you? They can give you an arrow here and ask you, ki, what is this? What is this structure? They can form or give you an arrow here and they can ask you. So you should know what all structures you can delineate from this CT scan of nose and paranasal sinus. So basically, this is whole of the sphenoid sinus that you can delineate here. And what is this? So this is your intersphenoidal septum, which is separating the right sphenoid sinus from left sphenoid sinus, right? And what all the structures you can see? The structure that is medial, infromedial, is the canal for median nerve, and the structure that is more laterally is foramen rotundum. So this is the short way of remembering that how you are. If you assume this as a sphenoid sinus, right and left, then median canal will be towards midline or medial, and your foramen rotundum will be laterally placed. So here will be your foramen rotundum and here is your median canal. So both the side similar things, median canal and foramen rotundum laterally. Now two more vital structures are there in the sphenoid sinus. When we enter with the endoscope into the sphenoid sinus, we can see one bulge here, which is for, if I change the color, So you can see one bulge here which is for optic nerve. So this part is carrying the optic nerve, and this bulge is due to optic nerve superolaterally, and this bulge that you can see here is bulge due to internal carotid artery, right? So this is your internal carotid artery territory, and this is your optic nerve. And what is the thing that comes in between? So the in between structure is called optico-carotid recess. See how easy? This is optic, this is carotid, and this is optico-carotid recess, or what you can say, your OCR. OCR is optico-carotid recess. Now you are able to answer and label what all things in this figure. You know by now that where is your median canal, where is your foramen rotundum, where is your internal carotid artery inside the sphenoid sinus, where is your optic nerve inside the sphenoid sinus, and where is your optico-carotid recess. So see how important this CT image was. And some bony structures that you can see are the pterygoid plates. So this is your medial pterygoid plate, this is your lateral pterygoid plate. So whole bone that is you are seeing is a sphenoid bone carrying the sphenoid sinus, right? This is your part of inferior turbinate, posterior part, and this is the midline. You can say the uvula that you can see, right? So we are moving to the next important image. So again, this is a variation of sphenoid sinus where you can see three types of median canal: type 1, type 2, type 3, depending upon where this median canal lies inside the sphenoid sinus. So in type 1, you can see the median canal lying whole into the sphenoid sinus, inside the sphenoid sinus. This is in the floor at the bony covering, and this is more into the bone. So these types are just to let you know that this median canal can be of these three different types. They are not going to ask you the different types, but yes, on sure basis they can ask you where the median canal lies in the sphenoid sinus. Why? Because there is a procedure called median neurectomy. So we all know about median neurectomy. That is a surgical procedure being done for, can I know what is the surgical procedure that is being done here? So name is for vasomotor rhinitis. Yes, I know you all know this. Now, may I know that, do you know how this nerve is formed? Can you comment in the section and let me know how the median nerve is formed? Yes, I'm seeing your comment through my mobile. So just let me know how the median nerve is formed. Yes, the anatomy part I just told you in that CT, the bare minimum that was needed, you will be able to answer it. They are not going to answer, means question you about the muscles, medial and lateral pterygoid based upon CD. Very less likely. Whatever was more likely we have discussed. Now you all know that this median nerve is formed by joining of greater petrosal nerve GSPN and deep petrosal nerve in the median canal, and that is why it is also called nerve of pterygoid canal or nerve of median canal. So basically this nerve of pterygoid canal or median nerve is formed by joining the GSPN, which carries the parasympathetic, and deep petrosal nerve, which carries the sympathetic supply. Okay, so this nerve of pterygoid canal is also called median canal, and we do a procedure called median neurectomy. This can be done in two ways, both endoscopically. We use the endoscope, and either we cauterize the median nerve branches at, like we do for sphenopalatine artery ligation or cauterization at the base of the middle turbinate. There these median nerves, some branches are there, we just cauterize them, or just at the sphenoid sinus like we have seen Here we find the nerve and cauterize or cut the nerve to relieve the patients of symptoms for vasomotor rhinitis, right? So my main aim is to cover as maximum images in less possible time. So let us see this second image and what is this line denoting to you. So yes, this is if I can know, yes, you are right. This is Ongren's line, right? So this Ongren's line was being used previously for squamous cell CA of maxilla. And what was the significance? This line, which is originating from your medial canthus to the angle of mandible, it is dividing the maxilla into two parts. One is suprastructure and another is infrastructure. So any tumor which is lying in the suprastructure and any tumor which is lying in the infrastructure both have different prognosis. Prognosis means different, you can say, the results after the operation. So in suprastructure, tumors will be more close to the orbit. They will be more close to the cranial nerves, and that is why these suprastructure tumor have a poorer prognosis. So this is the significance of this Ongren's line that is used for squamous cell CA of maxilla. So poor prognosis for suprastructure tumors. So always remember, just if you remember the concept, you will never make a mistake between which has poor prognosis. If you remember that the suprastructure tumors are more close to the orbit, more close to the cranial cavity, more close to the cranial nerves, and that is why they have a poor prognosis even after surgery, while the infrastructure tumors of maxillary sinus have a better prognosis compared to the suprastructures one, right? So this is the basis. Sinus is the floor of orbit. So one horizontal line is passing through the roof of the maxillary sinus. Another horizontal line is passing through the floor of maxillary sinus. So it is dividing it into again supra, meso and infrastructure, and the significance is again the same. Suprastructure, as more close to the orbit cranial cavity, carries a poor prognosis, and the infra carries a better prognosis, right? So in the same way of these lines, you can do the removal of the tumor. Like for infrastructure tumor, you can do infrastructure maxillectomy. You need not to remove whole of the maxilla and do a total maxillectomy. So depending upon this division, it also helps you to decide the surgery for the patient and the prognosis, right? Now there is one clinical picture which is given here, and they have also given you the name. So it's a Hebra nose. So condition called, seen in rhinoscleroma. Okay, so this Hebra nose or tapir nose is seen in a condition called rhinoscleroma caused by Klebsiella granulomatis, right? So this Hebra nose, tapir nose is seen in this condition, and the rhinoscleroma has different stages. So this Hebra nose is basically seen in stage 3 of rhinoscleroma. And one more important thing about this rhinoscleroma is about a pathological body. Can you name that body that is important here with regard to rhinoscleroma? So yes, these are Mikulicz body and Russell bodies. So both of them are seen in the stage 2 of rhinoscleroma. That means in a stage of granuloma formation. So it is a form of chronic granulomatous disease which is caused by a gram-negative bacilli which is called Klebsiella rhinoscleromatis. So one thing I just out of slip of the tongue it became, so it is Klebsiella rhinoscleromatis. Yeah, and it is also called fish bacilli. So it is caused by Klebsiella rhinoscleromatis, and it is also called Mikulicz disease or Hebra disease. The pathological bodies that we were talking about are the Russell bodies and Mikulicz cell. So if you see, there is submucosal infiltration with plasma cell, lymphocytes, eosinophils, Russell bodies and Mikulicz cell. Now what are these Mikulicz cells? These Mikulicz cells are the diagnostic for rhinoscleroma. These are the foam cells that will appear like this. So these foamy cells are the Mikulicz cells that you can see. So they can give you a histopathology, a clinical picture for the diagnosis. They contain the causative organism, that is Klebsiella rhinoscleromatis. Okay, and Russell bodies are the accumulation of immunoglobulins that are seen in the plasma cell. So if you see here, the more denser ones are the Russell bodies here, and the foam like foamy appearance cell are the your Mikulicz bodies. So Mikulicz bodies are the ones that carries the organism and are the diagnostic for rhinoscleroma. So don't forget this Mikulicz, because it is also called Mikulicz disease due to this cell. It contains the organism rhinoscleroma, that means Klebsiella rhinoscleromatis. Now there is one clinical scenario which is being repeatedly asked in all of your exam, which says that a clinical case of vertigo lasting for few seconds associated with movement of head posture. The condition was treated with Epilis. What is the diagnostic test? So I assume by now all of you know the answer. So among Helmich maneuver, Brandt-Daroff exercise, Dix-Hallpike and Epilis, what should be the answer? Just write it in the comments and I will get to know. Yes. So the answer here is, the diagnostic test is Dix-Hallpike test, right? So the answer is Dix-Hallpike. What condition we are talking about? We are talking about BPPV, and BPPV is something that is going to be there in your examination. So how you got the diagnosis? With the clinical scenario they have given. They are saying that the vertigo is lasting for only few seconds with associated with movement of head. So that means it has to be the most common cause of vertigo in ENT, peripheral vertigo, that is BPP. And again they have told that the treatment is by Epilis. So the most common form, that is the posterior canal BPPV, the treatment maneuver is Epilis, and the diagnostic maneuver is Dix-Hallpike. Now you should know how both of them look and how we perform them. The picture here that you can see, where the doctor has rotated the patient's head 45 degree towards himself. That means if you are examining the right ear, you will turn the patient's head 45 degree right towards you, and then you will make him lie with little abruptness. So first you will explain the procedure to patient, and then you will make the patient lie in the couch abruptly, head tilted around 30 degree down, and you will observe the eye of the patient for appearance of any nystagmus which has a characteristic of peripheral nystagmus. Okay, and this will fetch you the diagnosis of BPPV, and the maneuver is called Dix-Hallpike, right? So I'm not going into too detail because most of you know this by now, because this is quite often asked, and in your recent exam, in every exam it was there, right? So again, this is a Dix-Hallpike, and the therapeutic maneuver, you do this maneuver for treating the patient of vertigo for BPPV, right? So this is Appley's maneuver. Just watch a video over YouTube and you will get everything how Appley's is being performed. Another maneuver that they can ask you in future is Brandt-Daroff maneuver. So what is this? This is basically again a maneuver that is being done for the therapeutic thing. If you assume that by doing the Appley's maneuver, your patient didn't get relieved of the vertigo, what you will do, you cannot keep on repeating the Appley's in the chamber. You will advise your patient some home therapeutic maneuver, some home exercise. So this Brandt-Daroff maneuver is basically, it is a home therapeutic maneuver that you will advise your patient to do it when he arrives at home. Okay, so here what happens is, the seated patient begins by rapidly lying on one side and then waits until any provoked vertigo subside, right? So he'll abruptly lie down to one side, wait till any vertigo subside, then the patient sits up again and wait once more for vertigo to subside. The next move is to rapidly lie down on the other side. So if you see the diagram here, the patient lied abruptly to one side, waited for the vertigo to disappear, then again sat down, waited the vertigo to disappear and repeated the maneuver on the other side, right? So sequence is repeated 10 to 20 times up to 3 times a day until the patient is asymptomatic, and the symmetry of this maneuver makes it appropriate for either left or right sided pathology. So depending upon the pathology you will do this, and it also useful when one is uncertain to which side the canalolithiasis is present, right? So this is a important and nice exercise which a patient can do without any supervision of doctor, means he doesn't need anyone else to perform the maneuver on him or herself. So this is another pictorial diagram that you can expect in your NBE, coming NBE examination, that is Brandt-Daroff exercise, right? And the fourth option was Helmich maneuver. So you all know that this maneuver is being done to remove any foreign body that is stuck in the airway, right? So this session is going to be too important for predicting your future examination. So if you have any junior or your colleague, do share it with him also so that it reaches to the desired ones. Here the figure shows you one image where there is some cosmetic deformity in this beautiful face. So what is this? This condition is called hump nose. So basically there is a hump in the dorsum of the nose, and how you are going to do it, the procedure is called reduction rhinoplasty, right? So depending upon where the hump is located, mostly it is located in the bony part of the nasal, means nose, and what we do is with some instrument we grind or we remove that hump and make the cosmesis beautiful. So it comes under both ENT as well as plastic, because basically the results are more of cosmetic in nature. So the procedure that we do is called reduction rhinoplasty, where we are reducing the hump. There is another condition that is called saddle nose, where you will observe a dip in the dorsum of the nose, and that condition we do another procedure that is again called rhinoplasty, but here what we are doing is we are augmenting the nose. We are putting some cartilage, some crushed cartilage enclosed in fascia. What we do is we can take some nasal septal cartilage, we can grind it, we can crush it, and we can use the temporalis fascia, fill that fascia with the pieced cartilage and fill at the depression. Okay, so that what we are doing is basically we are augmenting the depression that is there. So this condition is called augmentation rhinoplasty. right? So here you can use different things. You can use iliac crest also, you can use ribs also to augment. So most commonly what we use is, we use the cartilage. What you use is pieced cartilage, means the small pieces of cartilage enclosed in bag of fascia, or you can use temporalis fascia. So this cartilage are long lasting, they do not dissolve rapidly, although there is tendency of dissolving, but uh, more or less they give good results and they last also. Other things are, you can use iliac crest, some ribs. So there are different things, different grafts that you can do to do augmentation rhinoplasty. Now this is another laryngoscopic picture which is showing you some lesion at the supraglottis and the glottis. So there are some lesion which is obscuring the anterior 1/3 of the laryngeal inlet. So just write in comments what are these lesions and how it is appearing to you. And if I give you a history of recurrence, that means a child has been presented to you with respiratory complaints and this condition is recurrent. Recurrent means he has been on treatment once, after which his respiratory distress reduced with some interventions, and then again he presented to you with this. So can you fetch the diagnosis with the clinical picture that I told you? So yes, it is basically the structure that you can see are the papillomas, and the condition that I explained you by the scenario is recurrent respiratory papillomatosis. And what you all need to know about this is the causative organism. So HPV 6 and 11 are more prone to cause this respiratory recurrent papillomatosis in child, and that is why it is called juvenile recurrent respiratory papillomatosis seen in children due to HPV 6 and 11, right? And why it is usually juvenile in children? Because these laryngeal lesions appear by infection of children through HPV while they are having, means delivered through the genital tract of women. So that is why these are mostly seen in their childhood period. Okay, so HPV 6 and 11 are more important. The treatment of choice. I want you to tell me what is the treatment of choice. So again here you can see some papillomatous lesion which is there in the, you can say, in the subglottis, or which is entering into the trachea and all. So these can be present in different regions. These can be in supraglottis, glottis, in the subglottis, and with variety of manifestation like hoarseness, like airway difficulty, and in some cases you have to do tracheostomy also to relieve the patient or to maintain the airway. Tracheostomy usually we try to avoid, because with the tracheostomy these lesions may spread to surrounding parts. But if the patient is in stridor, if he cannot be intubated, then the last resort to preserve the life, to save the life, is to do the tracheostomy. So our first aim in any emergency is your maintenance of airway, right? So airway comes first before anything. Airway, breathing, circulation. So always remember this for any management. Yes. So uh, yeah, so basically infant ETT tube. So basically the endotracheal tube that we use in infants are non-cuffed. Okay, so 2 to 3 size you can use, and the main thing is you have to see that they should not have any cuff. So mostly these are the non-curved endotracheal tube that we use in infants, right? Number is not that important, but the feature is they should not be cuffed. Okay, and another thing regarding them is the treatment of choice. So what is the treatment of choice? Treatment of choice is removal of these papilloma. So you have to debride it, and the treatment of choice is debridement by micro debrider. So there is one instrument called laryngeal microdebrider. So the laryngeal microdebriders, we use it to debride and reduce the disease burden in the laryngeal inlet. Okay, so this papillomas are, what they are doing is they are covering the laryngeal inlet and patient is having respiratory distress. Once you debride means removal. So once you remove these papillomas from the airway, the patient will be able to breathe, right? Your next goal is to prevent the recurrence that is happening. So that is why this condition, as this condition is prone to recurrence, you need to do something to prevent or to prolong the recurrence. So what else you can do? You can do you can advise your patient to get the nonavalent HPV vaccine. Yes, so this nonavalent HPV vaccine has a role in prolonging the recurrence phase. So by giving this nonavalent HPV vaccine, what will happen is your patient will present to you with the recurrence duration getting prolonged. So patient will be disease free for more duration of time. What you can do is you can advise her some topical cidofovir. So topical treatment, they have asked once ki what is the topical medication you can give in this scenario, is that is topical cidofovir. So topical cidofovir is also one of the modalities. Some interferons are also used. So there are different modalities that are being tried in this, and that is why this condition is really important, because in ENT there are some emergency, and this is one of the emergency if your patient is presenting with stridor, right? Now tell me, what is the diagnosis of this picture, this picture of fiber optic laryngoscopy? What you can see is, you can see two vocal cords here, but the thing is, in the anterior 1/3 part, the airway is not patent. There is some membranous like thing which is covering the anterior 1/3 or part of the glottis. So this is a condition called laryngeal web. So they are giving you different pictures of laryngoscopy, and you need to identify and you need to know the pathology. So these webs are formed due to failure of complete canalization of larynx. That means mostly these are congenital, but yes, they can also occur as an acquired condition if somehow the vocal cord get injured on the both the surface and the mucosa become bare. They can get adhered and form this type of a structure, but mostly these are congenital due to failure of complete canalization of larynx, and mostly they involve the anterior glottis, right? So occasionally congenital and occasionally it can be posterior, but mostly they will be located in the anterior part of the glottis. So these are the laryngeal webs that you can see. What you can do is, you can, with the help of coagulator, you can excise them and use some separators so that they again do not get adhered. There is one another picture which is quite similar to the previous one, but you need to differentiate between both of them. If you see here with focus, you will observe that both the vocal cord are appearing swollen, right? In the previous picture, if you observe, the lower part of vocal fold was normal. If you see this picture, the lower part of the vocal fold was appearing normal, but here both the vocal folds are appearing swollen. So what condition this can be? Yes, I can see. So it can be Rinke's edema, right? This condition is called Rinke's edema, where the fluid gets accumulated in the Rinke's space. Okay, and what you need to know about is there is a strong association with the use of cigarette smoking and heavy voice use. So in patients who are cigarette smokers, who have chronic voice use, they can get this Rinke's edema, and occasionally seen in middle-aged women where diffuse polypoidal changes occur in the vocal cord due to collection of things in the Rinke's space. Always and always, mostly they will be bilateral. So Rinke's edema is a sort of condition which is bilateral, and there will be diffuse swelling, which is an accumulation of fluid in the superficial layer of the lamina propria along the length of vocal cord, that means in the Rinke's space, right? Now, so you need to differentiate the Rinke's edema with the this laryngeal web and other vocal cord pathology. So this is another vocal cord pathology which is called vocal cord nodule. So very easy to differentiate vocal cord nodule. Why? Because you will observe bilaterally symmetrical sessile structures which will be a swelling in the anterior 1/3 and posterior 2/3 part, right? So posterior 2/3 and anterior 1/3 junction, you will observe bilaterally symmetrical sessile. So bilaterally symmetrical. Maybe I am little fast, but I want to complete most of the things, because by now you will be in your revision mode. You will have completed your one session of everything. So that is why I'm little fast, because I know in what phase you are going through. So bilaterally symmetrical sessile and at the junction of anterior 1/3 and 2/3, right? Mostly caused due to vocal abuse, like in teachers. So that in teachers it is called teacher's nodule or singer's nodule. This is something which you need to differentiate from a vocal nodule. Now this is something that is unilateral, that is pedunculated, right? And it is caused due to abrupt vocal fold injury, or you can say abuse. So abrupt injury to a vocal fold can result into a condition unilateral pedunculated like this, and this is a vocal fold polyp, right? Yeah, so this is a vocal fold polyp, and here the treatment of both vocal nodule and vocal polyp differs. So can you tell me what is the treatment of vocal cord nodule and what is the treatment for vocal cord polyp? Vocal cord nodule, usually we advise the patients some conservative thing for some months. So we advise the patient for speech therapy. We advise the patient on antacid, voice rest. So some conservative for some month, but in vocal polyp, we advise the patient for microlaryngeal surgery and excision. So the surgery is called MLS under general anesthesia. So we advise the patient to undergo microlaryngeal surgery, where with the help of microscope we first fix the laryngeal inlet, see the structure, and with the help of long microlaryngeal forceps, with one forceps we will hold it, and with another forceps, with the technique that is called micro flap technique, we will just raise. What we'll do is, I'll show you some steps of microlaryngeal surgery. we will give an incision here in the superficial layer, and then we will create the space. We will raise a micro flap. Why micro? Because this is a microscopic operation being done. We are using the microscope to magnify things. We will create a micro flap, and through that space we will remove this polyp and again repose it. So after the operation is done, you will get something like this. What we have done is we have given an incision, elevated it, removed the polyp, excised, cut it, we cut it with the scissor, and then again reposited the flap. So there is no need of any stitching and all. The flap will reposit, and a good excellent healing will be observed, and voice will return to normal, right? So it's a beautiful surgery, needs expertise and needs some amount of training. Now again a laryngoscopic picture which is depicting you a pathology. Can you name this pathology? But first of all, let us see what all we can see. So we can see one vocal cord here and another here, and some vascular reddish thing in the laryngeal inlet. So what it can be? So it can be a hemangioma, right? So there is a condition, a congenital condition called subglottic hemangioma. Why subglottic? Because this structure is seen below the vocal cords, below the vocal folds, and that is why it is the subglottic hemangioma, which is seen usually, the presentation is usually after 3 to 6 months of age. What the patient will present is the crying may worsen with stridor. Reddish blue mass below the vocal cord, below the vocal folds, you will be able to see. And if this is causing the child stridor, then you need to do a tracheostomy and some treatments for this hemangioma removal. You may go for a steroid therapy, you may go for CO2 laser excision, and what is important for your exam point of view is, along with the use of CO2 laser that you used to know up till now, there is one important drug that is called propranolol, which has a definite role in treatment of these subglottic hemangioma. So if they give you an option in the treatment of subglottic hemangioma, propranolol, mark it in the answer. Okay, so this propranolol, we first try to reduce the size and treat it with this, and then definitely the CO2 laser we can use it, because the lasers will cause the whole of the excision, but this propranolol is helping to reduce the size, and many a times with the use of propranolol things disappear, right? So again, their rapid growth in first year, resolution by 5 year, many a times they resolve also. And the main thing is to keep the airway patent for the child. So laser, 20% there is risk of inducing the stenosis, so using laser might cause the subglottic stenosis, and in acute cases tracheostomy might be required. Now here again some pathology you can see, and this is something which is very important with regard to ENT. The pictures that you are seeing here are a clinical presentation of laryngeal tuberculosis. So now you can observe what all you are seeing. So here you can see multiple nodular lesions over the vocal cord. Again, these lesions are causing the mouse nibbled appearance of the vocal cord. So there are certain features of this laryngeal tuberculosis that you need to know on sure basis. So just type me what all you know, so that I can get to know what all I'll need to supplement to you. So here you can see mouse nibbled appearance of vocal fold. Now tell me, what is the earliest sign? Earliest sign in laryngeal tuberculosis. I know you know this. So if you ask your brain to tell the answer, you just say your brain that yes, you know it. And what you can do is just take a tip from me. These coming 10, 20, or you can say these coming 3 months, just try to repeatedly say to you that you have got a brilliant mind and your brilliant mind will be able to remember everything. So what you need to do is you need to continuously, before sleep or after you wake up or while you are studying, you are taking a break, just try to say this one line to you: I have a fantastic memory and my fantastic memory is going to remember everything. You have to repeat this statement to you inside your, मीन्स व्हाट वी से इन हिंदी की मन में बोलना है, तो अपने मन में ये स्टेटमेंट 5 बार बोलो अपने आप को डेली कि आई हैव अ फैंटास्टिक मेमोरी एंड माय फैंटास्टिक मेमोरी इज गोइंग टू रिमेंबर एवरीथिंग. So what it will do is it will reduce the pressure your brain is having to remember everything in the exam. So this will help you to boost some amount of confidence your brain needing. So your brain needs some amount of confidence from yourself so that it remembers everything, and that confidence your brain will get with this statement. So try it, although it will seem silly, but it helps. So say 5 times daily to you that you have got a fantastic memory, your fantastic memory is going to remember everything, right? So straightforward, moving to the earlier sign, that is hyperemia of vocal fold. Earliest sign is hyperemia of vocal fold. So what you get is mucosal hyperemia and the edema, then interarytenoid mammillations, mouse nibbled appearance due to undermined ulcer that happens, turban epiglottis. You wrote right that turban epiglottis is seen mostly. This turban epiglottis is not due to accumulation of fluid but due to the nodules that get accumulated below the submucosally, and that is why due to that submucosal nodule you get a turban or swollen epiglottis in tuberculosis, right? There will be ulceration on the arytenoid and interarytenoid area, granulations, pale laryngeal mucosa, and one thing is ki why this posterior part of laryngeal inlet is more prone for getting these things like arytenoid, interarytenoid area, because in tuberculosis, mostly the tuberculosis of larynx is secondary to the pulmonary lesion. So mostly these are secondary to pulmonary TB. So mostly these are secondary to pulmonary TB, and what happens is that Mycobacterium, the tuberculi bacteriums, they, when you regurgitate the cough, the sputum, and again you swallow it, so that region, that sputum is going more towards the posterior part of the laryngeal inlet. It is staying there more, so that is why that area, posterior part, is more prone to get this tuberculosis of larynx, right? So most infection are sputogenic, that means they are caused by the sputum, and few are hematogenous, rarely by lymph stream. Primary laryngeal tuberculosis is also seen, but mostly these are secondary to a pulmonary lesion. Can infect the intact laryngeal mucosa, especially the posterior third of the larynx, and by now you know that why the posterior third is most common. Once you swallow the sputum, it will go and reside in the posterior part of the larynx, and that is why it is more common or affected. Now this is one of the questions that was asked in your recent AIMS, where they have given you a CT scan picture of nose and paranasal sinus, and they had asked you about anterior-most ethmoidal cell in the below picture. So this question I have already discussed, will be little fast with this. The answer is agar nasai, and they had marked you one structure here. So again, this anterior most ethmoidal cells, if it is pneumatized, it will be agar nasai. Now point to note here is, if they ask you most consistent or largest anterior ethmoidal cell, the answer will change. Can you let me know the answer in your comment? I know that your brain knows this. So it is, yes, it is bulla ethmoidalis. So bulla ethmoidalis is the most constant, or you can say the largest, most anterior ethmoidal air cell, right? But aganesi is the most anterior ethmoidal cell. This aganesi also marks a landmark while we do the functional endoscopic sinus surgery for frontal recess and then into frontal sinus. You just see this is the aganesi. Here you are getting your frontal recess and then the frontal sinus. So again it is marking a way to the frontal sinus. So just remember this aganesi is somewhere related with the frontal sinus. Here in the CT scan picture, which is the sagittal section, what you can see is you can see anterior ethmoidal cells, and from here you can see the posterior ethmoidal air cells. So anything behind this line is the posterior ethmoidal air cell. So what is this line? So I have been again and again talking about this line. This is the basal lamella. Basal lamella. Basal lamella or ground lamella, right? So basal lamella or ground lamella is the bony partition anterior to which the ethmoidal air cells are called anterior ethmoidal air cells, posterior to which are called posterior ethmoidal air cells. And what is this? Basically the basal lamella or ground lamella, this is the middle part of middle turbinate. So this, if you see this, this is your middle concha and this is continuing with this partition. So this middle turbinate has three parts: sagittal, coronal and horizontal. How you are going to remember it? With the mnemonic SCH, school. So nowadays children are very happy due to closure of school. So this SCH, sagittal, coronal and horizontal. The middle part of middle turbinate, that is this coronal part, takes a turn and attaches laterally to the lamina papyracea. Lamina papyracea is the medial wall of the orbit. Means the orbit is covered in the nasal cavity side by a thin papery bone that is called lamina papyracea, right? You all know this. So the middle turbinate, there is one part that attaches to that lamina papyracea, and that part is called the basal lamella or the ground lamella, which is the landmark separating the anterior from posterior ethmoidal cell. And behind this is the sphenoid sinus. This is middle and this is your inferior concha. This is your middle turbinate, this is your inferior concha. So lot more we have discussed with this CT scan. Again, this is your aganesi, anterior ethmoidal cell, posterior ethmoidal cell, sphenoid sinus. This bony partition was the thing that I was talking about, which is called ground lamella or basal lamella, right? Now one more important thing they can ask you in future is about anterior ethmoidal artery, and I have been repeatedly talking to you about this anterior ethmoidal artery. If I draw it with the red line, which, so to show the anterior ethmoidal artery, I have chosen a red mark here. So this is the course of anterior ethmoidal artery, which is exiting from the orbit into the nasal cavity between the superior oblique and the medial rectus. Okay, there are two intraauricular muscle, medial rectus and superior oblique. Between these two, the anterior ethmoidal artery is exiting from orbit into the sinonasal cavity, and this point, this conical point, is called Kennedy's nipple. Okay, double N. So Kennedy's nipple. So you should know this if they ask you in future exam, that this marked structure is your anterior ethmoidal artery, and many a times during surgery usually it is covered with bone, but we need to see the CT scan to know that whether the bone is present or not. So many a time the artery is lying naked, that means there is no bony covering, and then there are high chances that we might injure the anterior ethmoidal artery. And why ENT surgeons fear this while doing FACES? Because if this artery is injured, what happens is this artery retracts into the orbit and causes bleeding. So we do not fear for any artery. If we can take control, we can, if that artery is approachable, what we can do is we can just cauterize that artery. We can hold the artery with the artery forceps and tie it. which happens during usual surgeries. But now what is happening is this artery, after injuring, this artery is retracting inside the orbit, and then we cannot catch hold the artery. This artery, what it will happen is it will keep on bleeding, and as this orbit is a closed cavity, it will cause compression to the optic nerve and patient may lose vision. So there might be loss of vision. That is why if you see during FES, we keep the side that we are operating, that side eye, we keep that open, because if anyhow this artery is injured, we have to see whether the eyes are getting bulged or not, to see whether bleeding is occurring inside the orbit. And then to prevent this loss of vision, we do an emergency procedure that is called lateral canthotomy. What we do is we excise the lateral canthus so that this eye can get some space to expand, and loss of vision due to compression to the optic nerve can be prevented. So that procedure is called lateral canthotomy. Okay, now this instrument was asked in AIMS. There will be a separate instrument session that I'll upload in the Unacademy app if you are there. So this is a Molleson's mastoid retractor. The full name is hemostatic self-retaining Molleson's mastoid retractor, because it is due to compression, it is hemostatic, self-retaining due to this, right? So a clinical, this we have already discussed. It's a repeat. Now some oral cavity conditions that they are asking nowadays. So one question they had asked was about the peritonsillar abscess. Peritonsillar abscess, that is also called quinsy, and how you are going to differentiate it with the parapharyngeal abscess. Okay, so peritonsillar abscess or quinsy and the parapharyngeal abscess. In quinsy or peritonsillar abscess, what all you will observe is your anterior pillar, your tonsils, they will be angry looking. They will be very angry with you that why are you going to treat me? So there is some infection in the peritonsillar space that is causing, and the tonsils, that is causing this angry looking, and there will be deviation, pushing of the uvula to the other side. So if you see, this is your deviated uvula. So usually uvula lies in midline, but due to that tonsils and the pus, collection of pus in the peritonsillar space, this is causing, pushing the uvula to the opposite side. So there is deviation of uvula. But this deviation of uvula, pushing of tonsil medially towards the midline, is also present in parapharyngeal abscess. Then what is the difference? The difference is the parapharyngeal abscess is not angry with you. That means the parapharyngeal abscess doesn't look angry, because the pus, the infection, these all are lying in the parapharyngeal space, which is far behind the tonsil. So here the infection doesn't lie in the peritonsillar space or the tonsil, and that is why you don't get these angry looking things that you get in the quinsy or peritonsillar abscess. Signs will be almost same. There will be fever, there will be pain in throat and others, because anyway abscess is there, so all the toxic signs will be there. Now there is one condition called infectious mononucleosis, where also you will get this membranous type of thing and the tonsillitis. So this is a clinical picture showing you infectious mononucleosis, also called kissing disease. Here also you will get fever, malaise, pharyngitis, cervical lymphadenopathy, and the test is heterophile antibody test. Treatment is mostly supportive. So you must know different condition that is causing membrane over the tonsils and other area. This condition is very peculiar of something called diphtheria, and how you can get a diagnosis of it is there will be a peculiar history of non-immunized child. So mostly it now occurs in those who are not immunized, because we have DPT immunization as a regular thing in the national immunization schedule. So here also you will get a membrane a whitish grayish membrane which will bleed on removal. So it will be a pseudo membrane, you can say, which will bleed on if you try to remove it. And this is highly infectious disease, so diphtheria. Okay, another thing is Vincent's angina, which is also called acute necrotizing ulcerative gingivitis. So here also you will get the patchy lesions in the oral cavity with gingivitis. So you should also know that there is something called Vincent's angina, which is basically occurring in poor dental hygiene and in immunocompromised patient. Now, as I said, immunocompromised patient, there is another condition called oral candidiasis. So you all know that this oral candidiasis, where you will get this sloughy white patches deposition over the oral cavity. It can be discrete also, it can be a patch also, usually occurring in immunocompromised state. So any history of immunocompromised stage, or any history of usage of oral corticosteroid sprays and all, so these, like in asthmatic people, so this oral candidiasis can occur due to decreased local immunity due to steroids. Membranous tonsillitis, you all know, where this different this tonsillar crypts, they join and form a membrane. So acute membranous tonsillitis, a stage ahead of acute follicular tonsillitis, where the exudation from the crypts combine to form a membrane on the surface of tonsil. Okay, so it occurs due to pathogenic organism, and again the signs and symptoms will be same. There will be swollen tonsil, hyperemia on the pillar, uvula and soft palate, like this. Okay, and this is something that is very painful to patient. So do you know this condition? I'm watching the comments. Do you know this condition? This condition, which is white in the center and reddish surrounding area, and it is very painful to patient will come to you. It will look so small that you will think why the patient is bothering, but in real this is really painful. So just name the condition, and I'm watching it, what you are suspecting your patient to come with. So this is a aphthous ulcer. So this condition is called aphthous ulcer. Mostly it resolves in 7 to 8 days. So mostly it resolves on self. You mostly give B complex, vitamin B complex and some local analgesic gels to the patient, and because it is the cause is not known, so it resolves spontaneously. These can also be recurrent, so many patients can come to you twice or thrice and within a year with this aphthous ulcer, and if they are more than 1 centimeter, these are called major aphthous ulcer, means big major one, right? Now there is something called adenoid facies. You just need to identify what all features are present, why it is caused. So it is mostly caused due to adenoid hypertrophy in children, if it is for a long time. So many a time parents miss their child with this adenoid hypertrophy, and that results into some characteristic features like pinched nose will be pinched. Why? Because nose is not being used, so there is not use of these ella and all, and that causes hypoplasia of the ella muscles and all, and results in pinching of the nose. The patient is not breathing through nose, the airway, the nasal airway is blocked behind with the adenoids, right? So that is why patient is having mouth breathing. You will observe that the child will sleep with open mouth, or the child will sleep in opposite, means the mouth and all, he will sleep with, means the opposite direction in supine, so that he can breathe, because adenoids are closing the nasal airway. So there will be narrow pinched nostril, high arched palate due to more usage through the mouth, crowded teeth, dull mask like face. So many a times these are also called idiotic face. Why idiotic you can say IQ wise also they can be sort of idiotic. Why? By this I mean that they are low in intelligent quotient or low in learning. Why? Because these adenoids, what they are causing is they are causing blockage of the eustachian tube, that is in turn resulting in the otitis media with effusion in the ears. So what is happening is there both the ears they have fluid, and that is why there is a conductive hearing loss in this patient. So whatever you tell, whatever you try to convey to the child for the learning purpose, he is not able to hear. So if he doesn't hear, how will he be learning? So that is why these can means mostly they have less learning, idiotic type. Okay, so dull like face, protruding teeth, drooling saliva, and loss of nasolabial fold and all. So here for the diagnosis, mainly in OPD purpose, we give soft tissue lateral view of nasopharynx. So soft tissue X-ray, lateral view of nasopharynx. What you need to see is this is your airway, your nasal airway continuing into oropharynx, then pharynx and other. So here you will see there is one protruding thing, that is adenoid. Many a time this adenoid is so big that it fills whole of the airway, and then we say it to be adenoid hypertrophy. And if it is filling whole of the airway and causing symptoms, what you do is you do adenoidectomy. Okay, so this adenoidectomy can be done with different procedures. You know, the most commonly is cold steel, and the most advanced, or the you can say now the treatment of choice is with the help of coagulation. So this coagulation, what we do is we say the surgery is almost bloodless surgery. Okay, so this coagulation technology is very helpful. What it does is it evaporates most of the adenoid tissue, and you need to know about this coagulation. The wands are there that we say the like ProSize Max. So you should just Google the coagulation wand and see the image. Otherwise I'll post in your Telegram group. It is something like this, a strand with a tip having some metals in the tip, so they can give you a image of the wand of wand of coagulation so this is a highly probable image for your future exam, because this instrument has revolutionized the ENT operation. This coagulator we are using in the nasal surgeries, in nasal angiofibroma surgeries, and all other things, in sleep apnea surgeries. So you need to know about this coagulator and the instrument, right? Now this is a condition that is caused due to one pathology. The condition, the child, you can see here, he is protruding his mouth and the neck. So this is sort of swan neck. Okay, so he's trying to open his airway by this position. The hands are on the front, trunk leaning forward. So this is called tripod sign, and what the child is trying to do is he's trying to open up his airway for breathing, because the airway is closed due to acute epiglottitis, where the epiglottis has swollen to an extent that it is closing the airway, right? So if you see, this swollen epiglottis is closing the airway, and we get a sign that you all know is called thumb sign on X-ray. Okay, so it is seen in acute epiglottitis. The condition you all know, management you all know. This is just to give you a clinical sense or the image memory for these condition if they ask. So they can ask you anything related with epiglottitis with this image. Here you can see swollen epiglottis filling almost all of the airway. So if something more enlargement occur, the patient will not be able to breathe, and it will be sort of emergency condition. Now there is another condition where there occur, you can say, narrowing of the airway, anteroposterior narrowing. So basically it occurs in the subglottic region, and this you all know that it is seen in a condition called croup. The sign is called, so if you see this type of thing, you will be able to see here. If you delineate with the AP view X-ray, the airway is narrowed at this point. This is called steeple sign, seen in laryngotracheobronchitis. The cause of epiglottitis was Haemophilus influenzae type B, okay, hip. And in more advanced cases, as people are getting immunized, it is strep. It's strep pneumoniae. But in case of croup or laryngotracheobronchitis, what is the causative organism? I'm seeing the comments, just let me know. So I know the session is getting prolonged, but I cannot stop myself from discussing because these all are so important. Yes, pencil tip, causative organism. Causative organism is a virus, that is parainfluenzae type 1, 2 and 3. So it is caused by a virus. The treatment here is mostly supportive with the epinephrine and all and the steroids, and in epiglottitis you need to give antibiotics because the causative organism is a bacteria. So the treatment of choice is, apart from the supportive, the epinephrine, steroids and other, you need to give antibiotics here, IV antibiotics. This X-ray shows you the most common fracture that is observed in ENT, that is nasal bone fracture. So there is a fracture of dorsum of the nose. What you need to remember about is the management. If the patient is presenting to you acutely on the same day, you can do the reduction. That means you can do the open reduction, or the means basically you can manage that fracture on same day. But if he is presenting to you on the second day, third day, you usually try to postpone it 4 to 5 days so that the edema disappears. So you do not want to operate patient when the patient is presenting to you with surrounding edema and the vascularity. Why? Because while you operate on these patients with edema, there will be more bleeding, more vascularization, more bleeding, more pain, and the results will also be not that good. So the most appropriate time is either immediate or after some 4 to 5 days. That means at 5th to 10th day of the fracture. So this is the common thing that you need to remember about this nasal bone fracture. Now some X-ray views from paranasal sinuses. The common one, you know, that is occipitomental view. I have already discussed it, so not giving you that picture again. Occipitomental view and the Waters view, you all know. Then another thing is Waters view with open mouth. So if you keep the mouth open, that is called Peary's view. So this Peary's view was asked in your examination, which is Waters view with open mouth. Why open mouth? So as to see the sphenoid sinus. Waters view was best for maxillary sinus. So this was also asked once in your examination, that Waters view was best for maxillary sinus. Peary's view, here you what special is Waters view with open mouth, where you can see sphenoid sinus. And in Caldwell like views, which is your occipitofrontal view, you can see your frontal sinus, your anterior ethmoids, your maxillary sinus better. Now there was one question, which sinus is usually not seen in the Waters view, or is this Caldwell's view and others? So mostly your posterior ethmoids are difficult to see with this sinus views. Now this lateral tissue X-ray, soft tissue X-ray of nasopharynx is showing you a sign. So I will end this session with this sign because it's already 1 hour and you will get exhausted with so much of things. So I'll arrange another session very soon We'll end this with this important diagram. Tell me, what is this clinical X-ray showing you? What condition? So this is showing you something called crescent sign or dots sign, right? So if you observe here, in adenoids, what you will observe is you will get some airway here because adenoids are bulging in this area, but here something, a crescent is found here, that means above this. So in cases of antroconal polyp, in AC polyp, you will get this crescent sign or dot sign. So what is that? This is a air column above the mass. So here if you observe, some mass is coming from the nasal cavity behind into the nasopharynx, and above that a air column is present. So that air column is forming this crescent sign or dot sign. They have asked this in the that CMS examination and in one NBE examination, that the crescent sign is seen in, so it is seen in antroconal polyp. I don't know whether you know this, but I have seen a lot more students who don't know this crescent sign. So that is why this dot sign or crescent sign is important. So I'll just name them because I was going to end, but I'll try to just name them. You just know this is a coin in the oesophagus. The difference is in the lateral you will get like this. Now if it would be in the airway, it would be slit like here in the anteroposterior view, and in lateral it would be like this. This is for a bird beak sign, which is a barium for achalasia cardia. This is a teapot sign where you can see CSF thing leaking down. So this is a free flow of free fluid like CSF, a teapot sign which is seen in CSF rhinorrhea. This is a target sign, again seen in CSF rhinorrhea, but not a normal CSF rhinorrhea, in traumatic CSF rhinorrhea where some fracture or something has occurred where you are getting blood mixed with CSF. This is a Liar sign seen in carotid body tumor, right? Liar sign seen in carotid body tumor where you will observe splaying of the carotid artery. So there is splaying, there is widening, splaying of the carotid artery around the tumor, which is called Liar sign. So it is a paraganglioma. Again, one important sign that is called Phelps sign, where you get this Phelps sign. The important is you get it in the glomus tumor. Okay, and what you get is, usually in normal glomus tumors there is a normal bony separation, a bony crest between the carotid canal, which is housing the carotid artery, internal carotid, and the jugular foramen. So these tumor, what they do is, due to the pressure and other eroding properties, they erode the normal crest that is present between the carotid canal and the jugular foramen, and that we can delineate in the CT scan that this is a case of glomus tumor or glomus jugulare, where they are eroding the normal crest that is present between the carotid canal and the jugular foramen. This X-ray is showing you a teardrop sign. Why teardrop? Because the fat and other things are projecting into the maxillary sinus due to a fracture in orbital floor. So this is caused due to most common the fracture of the orbital floor, resulting into a teardrop sign, right? So I think we have discussed a lot more important things today. Do let me know how this session was important for you, how you liked it, because these comments are really important for me to get the feedback. And I know I was little fast, but I just wanted to save your time because your time is precious. And just remember my words that you are going to do it, you will do it. Just keep on working, keep on giving your efforts every day. Everyday efforts will finally make things big and your journey successful. This is Dr. Shivam. Hope things work out for you, and live a happy and healthy life. Signing off.